from a consumer perspective, I just want you to know how much your faith in us as clinicians makes a difference for what we can do, because it really sort of forms the base for giving us the courage and commitment to really do whatever needs to be done. And none of us take that lightly. And special thanks to Carol for inviting me here, even though she knows me, she still invited me. So can everybody hear me okay? Okay. So my background was in oncology and bone marrow transplant before I went to interventional radiology. And I did that because I was working on a phase 1 trial with one of the IR docs, and he recruited me. And I'm like, I think you're all a bunch of weirdos. You like work in the dark in the basement with these like monitors everywhere. And, the rest is history. But anyway, so, most people don't know what interventional radiology is. And basically we're clinicians who use different imaging modalities to diagnose or treat a variety of problems. A lot of that is GI related, some of it's chronic kidney disease, a lot of oncology, but we really cover every body system, and we use different imaging modalities to get the job done. We're one of the specialty practices around the world that manage, place, treat vascular access device problems. There are other practices that do that as well. Some good surgery practices do that. Unfortunately, there's a lot of variation. So it pays to be a knowledgeable consumer, and everybody at Nutrishare really knows this. So no matter where you are in the country, they can help connect you to a really good practice and help get you there. If you're maybe in a remote area or whatever, you need some special expertise because of venous occlusion, anything like that. Okay. So the different modalities that we use are ultrasound, fluoro, CT, MR. They're all different, and we use them for different purposes. So what does it mean for vascular access? It means we use them to identify a target, and the target would be the vein that the catheter or device goes into, to assess device function. You might say, you know what, all of a sudden I have a really sluggish blood return, or I have resistance to infusion, or, it hurts when I do this, that, or the other thing. Just, one important take home point, your line should never hurt. Ever, ever, ever. If it does, something is really wrong, and get somebody to investigate. That's just not normal. Nor is if I go into my infusion center and they tell me to, stand up, rotate my arm back, cough, no, no. We also use it to vein map. I'm going to talk a little bit more about vein mapping in a little bit, which is basically us making that map to see what veins are available, how big they are, where they are, so we can get a device somewhere. So if you come to me and you say, you know what, my practice or whoever said to me, I don't have any veins left, my response is, let's prove it. Okay, because I don't believe it unless I prove it. And if you come to me from Mallinckrodt in St. Louis and they said it, I'm going to believe it, but I'm going to want to see the images. But, it's got to be a really top-notch place for me to believe it. And I want to see the data that shows that it's true. Okay. Because you know what? It's very rarely true. How many of you have been on TPN for, say, more than 10 years? Okay. You all know a guy named Don Young. You know Don Young. Okay. Okay. Don was on TPN for more than 40 years. And people told me he was centrally occluded. He wasn't. We can get here from there some way. So I wish he was still with us, an amazing gentleman, but he's an example of somebody where, where there's a will, there's a way. We'll get there. Okay. We can also treat thrombus. We can treat fibrin sheath. We can treat occlusions in IR with all sorts of different tools like balloons and radiofrequency loaded wires and stuff like that. And I'm going to show you some of that. Okay, so here's typical use of ultrasound in the IR suite. So in terms of the orientation here, that's me over here, and the patient's head is right under that part of the drape that is sort of like a tent, feet down at the bottom. And do we have a laser pointer? Oh, we do. Sorry. Yep. Thank you. So here's the ultrasound probe. See the collarbone right here? So the ultrasound probe is here, and you see that dark circle there? So that's the internal jugular vein. So anything that's fluid filled is going to look dark. So that's how we know, based on that ultrasound image, what that vein is, where it is, how big it is, and whether it's what we call patent, meaning open. If there were clot in it, anything like that, we can see that. Okay, and here's a better image. So here's internal jugular vein. This is carotid artery next to it. That's where we do not want to go. But it's very easy for us to see. And what we do is in real time or live, we get our needle into the vein. So we'll either come in sort of this way or this way. It's going to depend upon what the individual presentation is, how big somebody's neck is, how much somebody can turn their neck, all sorts of things like that. But that doesn't really matter. We just want to get into there. So how do we tell where we want your catheter tip to be? Well, one way, and the old way, is X-ray. And everybody would say, oh, you know, that's the way you do it. It's really a really old way to do it. And it involves a little bit of guesswork, to be totally honest, because you can't see a vein unless you put contrast in it. And contrast and dye are the same thing. So here's a line coming up from here. And there's the tip of it. Okay, can you all see that? Okay. So why do we know that that's the right place? Well, we use surrogates. So here's your trachea. So the reason you know that is, see how it's sort of grayer? Lung, right? It's more gray or dark. That's because it's air-filled space. And you come down and you see what's the right main stem bronchus, or the breathing tube, to the right lung, and then the breathing tube to the left. So when we look at X-rays and images like this, it's like looking in the mirror. So this is really the right, and this is really the left. So think of it like looking in the mirror, okay? So that's the tip, and we use, based on either vertebral bodies or where this right main stem bronchus is, we say that is the junction between the superior vena cava and the right atrium. Like, you don't really know, but it's like about right, okay? So maybe that sounds a little bit crazy, but you don't have to have a catheter that's like 17.55 centimeters long. There's like sort of like probably about 4 centimeters that'll get you in the right place. And that catheter tip is not fixed. So when you move, breathe, whatever, you move your arm up, it moves your catheter tip. So don't be too worried about, you know, it has to be this exact number. What it needs to be is approximately right there. Okay, so X-ray is one way to do it. Fluoroscopy just means like a video version of an X-ray. Okay. The other way to do it is with ECG tip location technology, which is now FDA approved for both PIC placement and port placement. It's very interesting that the port business has not changed since this has been approved. But if you have a PIC and you have a really strong vascular access team, they are the best, these nurses, the best. At doing this, they'll have a little monitor that goes on the waveform of your heart, and that's how they'll determine that the tip is in the right place. And honestly, that is way more accurate than this. Okay, so here's another example of what the landmarks look like. So here's your trachea, main stem bronchus, and see how there's like this line here. It almost looks like a dotted line here and here. That's the right main stem bronchus. Here's the left coming off, and here's your catheter tip. So we just use basically these anatomic landmarks as surrogates. Now, if you want to really know for sure, you inject contrast or dye. Contrast and dye are the same things. So this is an injection of contrast from the left arm. Okay, so left is here, right is here. Here's the subclavian vein coming up. So this would be somebody who has an IV in the arm and is injecting, and we just step on that pedal, that fluoro, that's the video version of an X-ray, and we watch this contrast come up. So see this little thing here, it looks like a curly Q. This is the left internal jugular vein joining the left subclavian vein, crossing over. Again, it's a little darker here. That's because the right internal jugular vein is coming in. You don't see the contrast sort of flow backwards here, but that's why it's like this, and then come down. And so the SVC is the superior vena cava, and here's where the right atrium joins. Okay, so this is right where you want to be. It goes out your heart to your lungs. It's called the pulmonary artery, even though it's vein, right? That throws you off. That's non-oxygenated blood. Pulmonary artery is going to your lungs to get oxygenated, but that's the pathway that it follows. All these little curly Qs here, those are wires. Those are sternal wires. So this patient has had an open heart surgery, and those are the wires that holds the sternum together. Completely irrelevant to what we're looking at here. Okay. Any questions about that? No. Okay, so here's another example of a catheter coming in from the right side. So this is a large catheter. You can tell that because it's just fatter, right? So it comes in from the right internal jugular vein. We know that because it's above the collarbone or clavicle and an accurate tip position. This doohickey is a snap on the patient's gown. Yeah, like, I think like they swallowed something and it stayed in there, which can happen. But the take home point about this is that you have this nice wide curve on the catheter, and that's going to translate into better device performance, right? If this were like a tight turn, right, it's going to impede flow. So you want that, but y'all don't want your catheter out over here, right? Because every time you move your arm, it's going to drive you crazy. Bra straps, very important. Sorry, guys, very important. Okay, you don't want that. And when people are new to access, they don't think to complain about that because they don't know it could be any different. I know it could be way different. And I teach a lot of guys and I'm like, look at, this is important. Don't go there. Oops, sorry. Okay, so vein mapping is a roadmap. So let's just say I get a referral for somebody, really, really sick patient. They've had a bazillion lines. They've had a bone marrow transplant, heart transplant, you name it. And the people that call me in the ICU say, you know, oh, we got nothing, you know, and I'm like, okay, you know, so there's several ways we can do it. The least invasive, the fastest way to do it is with ultrasound. Somebody like me or a technician stands there with a probe and looks at everything. The problem is you cannot see the superior vena cava with ultrasound, right? Because you can't see through the sternum or the breastbone, right? So you can only see the stuff in the neck and the arms and the groin if we had to go there, okay? So you can do, I should have it on here. It's actually called a CTV, which is the gold standard, CT venogram. So the diagnostic people do that. I say, I want base of skull through diaphragm if I think I can be somewhere in the chest. And they will map out everything for me. So I know where it is, if it's patent, how big it is, you know, if there's what's called a stenosis, which is basically you're taking a 5-lane highway to a 1-lane highway. That doesn't mean we can't get through it. It might mean we have to balloon through it to get it open, but it doesn't mean we can't get there. So CT venogram is great. The only caveat with any of these contrast studies is that it depends upon decent renal function, okay? Because we're going to give contrast or dye and your body gets rid of that through your kidneys. So if you have really bad kidney function, we don't want to challenge your kidneys by doing that. So that's something you wouldn't want to sign up for unless you had to. When we inject contrast, like that image you just saw, I can do that with about 20 mLs of contrast as compared to a regular CT, which takes 200. So that's the difference between about 2 tablespoons and a cup of coffee. Okay, so big difference. MR is not that practical. We can map with MR, but it's hard for us to do procedures in MR because the magnet and our needles are stainless steel and they don't go together real well. But we're working on that technology. So here's an example of a woman that many of you know well. I adore her. She was told she was occluded and she's not. Her SVC is occluded and everything in her neck is occluded except for a collateral vein. So a collateral vein just means a vein that was always there. It's not a new vein. You don't make new veins, but it's a small vein that was there that takes over the flow when a bigger vein that was initially there is blocked. For example, you know, you're going 95 from New York to Florida and there's a big wreck on 95 and you can't get there. So what you do is you take the side roads, right? You can still go south and everything, but you're going to do all these side roads. That's exactly what your blood does. Okay, side roads. And so that's why if you've had a lot of lines and you have some occlusion, sometimes you see what looks like varicose veins on your skin and your chest, because those are like normal small veins that had to get bigger because they had to take over that flow. Okay. So this is what's called an azygous vein. So normally your azygous vein is not that big. And I think it looks sort of like an elephant trunk. So normally you would see this contrast come down, and just like we saw in those previous images, you would sort of see this thing that looks like a funnel straight down that would be your superior vena cava. But in this case, that's completely blocked. So you don't see that, but what you do see is this vein here that looks like it dead ends and then comes up and over and around. So this is where we put her port. So most people would look at that chest x-ray and say, well, somebody done a bad job, right? Like, what the heck were you thinking, right? I think this port lasted about 5 years. So we're just in a collateral vein, one of those little skinny side roads, down, up and around, and tip here. Okay. So you can do it. You just, you have to have a clinician that's committed to doing it, honestly. That's, Here's, this is an example of a cross section on a CT. So if you think of, when you look at CT images, it's like, I'm here laying down, my feet are toward you, and you're slicing me like pepperoni. Okay, so in this case, you're looking from the feet up. And so here's the left again, here's the right. And see how you see this little white circle there? That's what the contrast is going to look like. And so this is a young kid awaiting liver transplant who was told, there's nothing, and, no way, right? So you can see that there's contrast in there. So if there's contrast in there, then there's flow. And then we follow it down. You just, all these different slices, right? Slices of pepperoni, follow it down, and we can see, oh, you know what? It still goes down. Okay, this is the spine, lung, scapula. And then we inject, so we get into it and we inject dye into it. And you see all this curly Q looking stuff. When you see that, those are all collateral veins. And when you see that many like that, you know that occlusion has been present for quite some time because those collaterals are so well developed, right? And you're like, oh, dang, that doesn't look good, but this part isn't bad, right? These are lumbar veins, so why not? There's your line. So again, people would look at that and say, oh, this patient must have some very weird anatomic variant that, there's this thing called insitus reversus where your, stuff is on the wrong side. No, she doesn't. She just doesn't have very much left for veins. Okay, so this is a hemiazygous vein. So where the other one went sort of like this one goes like this, and that got her to liver transplant. What about when your catheter doesn't work very well? And a lot of times what'll happen is that you can flush, but you can't withdraw. And you're like, I know this is, why won't I get a blood return? And that's because of something called a fibrin sheath. So this is what a fibrin sheath looks like. So this is just 10 mLs or 2 teaspoons worth of contrast. And we inject it into the catheter. So you can see how here it looks nice and crisp. And then here it's like all murky and there's some dark streaks and then there's some light streaks. All this stuff where it's light is fibrin sheath, okay? And the reason it looks like that is because it's taking up that space and the contrast can't get in there. So if you ever read a report that says a filling defect, that's what it means. It's a filling defect because the contrast can't get in there. And so that's a big fibrin sheath. And 1 dose of TPA is not going to do the trick on that. We're going to have to drip some TPA over a couple hours. We can bust that up with a balloon, or we can strip it off your catheter. There's lots of different things we can do, but that's why catheters don't work. And it's your body's way of just trying to protect itself against a foreign body. So your body thinks it's doing the right thing, but not so much. And here's what it looks like when we take it out. All this, it looks sort of slimy, but it feels like really fibrous and tough. Normally it doesn't really come out with a catheter, but this was sort of a lucky day in that it did. So you can see it really sticks to the catheter, and you think, oh, I could just pull that right off, and you can't. You really have to sort of claw it off to get it off. But it makes sense, right, that a catheter wouldn't work because it gets in these little side holes in the catheter, and when you go to pull back and you exert some negative pressure, it just sucks into the hole of that catheter, and that's why it doesn't work. The fibrin sheath, as I said, does not necessarily come out with a catheter. So here's an example, right? It looks like there's a catheter in there. There's not. That's a fibrin sheath that's left behind. So we want to treat this stuff seriously. Now, there's really nothing you can do about that. We see it all the time. It can happen from just one catheter placement. But if you're new at this, you'll be mistaken and think, oh, there's a catheter there. There's not. That's just that sheath that was around the catheter. When you took the catheter out, it came out and left this, what I call schmutz, behind. And you know what, when I moved to California, I realized how much Yiddish I used. People got the schmuck part really quickly, but And so this patient has had 2 catheters, right? So you see, right, doesn't it look like the catheter is still there? So this is sort of a sideways view. Right? So, I mean, we don't really have to work around that or anything, but has anybody ever had their line exchanged? Okay, so exchange is not a good strategy for a fibrin sheath because this stuff oftentimes is still there. So you exchange your catheter over a wire and you send your new catheter right in the middle of this stuff again. So there's reasons to exchange a catheter, but fibrin sheath is not one of them.
It's really new, right? It's a brand new catheter, has like a malfunction. It's time for that, right?
Well, I mean, it can occur pretty quickly within days.
Okay.
So what you want to do is you want to have somebody inject that catheter and see why it's not working. You know, the first thing we do is take just what we call a scout, just take a picture of it. You know, maybe there's distortion in it, maybe there's a kink in it, something like that we could see really easily. And if it looks perfect, then we'll inject it and see, you know, what is it? I mean, you can imagine, right? One of these catheters could not even be in the vein, you know. Okay, so catheter tip position. So here's a catheter, right? That's here. So it's coming in here, really bad turn here, right? Like really bad. That's going to not give you good flow, but then it comes over and instead of dropping down like this where it should be, it's over here. So it's butting into the side of the SVC. A lot of patients will feel that. They say it hurts. But when we inject it, right? See this little ditzel here where like nice big vein, then it's skinny. That's what happens where you scar that vein because you're infusing whatever, something that's hyperosmolar like TPN or whatever, all different kinds of medications, and it scars the vein. So catheter tip position is important in terms of performance and in terms of risk of clot and risk of stenosis. And stenosis just means scarring of the vein. This is bad. We're going to have to balloon that open. And this is how we do it. So there was a catheter here. We put a wire through it and then we load the balloon. So it's sort of like a monorail kind of thing. And we put some contrast into the balloon because we want to see exactly where we're putting the balloon. So there'll be little markers at the beginning and the end of the balloon. And in this case, we knew that the scarred area was here. So we blow up the balloon and you can see this like indentation here. That's where the scarred vein is. It's narrowed down. And these balloons are not like the latex balloons that you think of in a birthday kind of balloon. These are like hard as a rock when we blow them up. So what we do is we keep blowing it up until we see that pop and open up. And so what we've done is we've stretched the vein back open. Seems sort of awful, huh? It's not, it works. If we have to, we'll leave a stent. So here's a stent. Think of it like a Chinese finger trap, or if you had a screen in your house and you cut a piece of it and you rolled it up like a cigar. So what the stent does is the stent provides structural support to keep the vein open, because sometimes we balloon it open and then it wants to recoil or come back down to where it was, right? So we try not to leave a stent in because you don't know how long a stent is going to stay open. But then we can bring our catheter right down the middle of the stent. These are different than cardiac stents or stents in your heart. You don't have to be on blood thinners and stuff like that to have a stent in your vein. The other way we can get through tough spots is with radio frequency loaded wires. And so it's a little wire and it's basically like got a heated tip on it. And we just sort of, you know, you think of the people who built the subways in New York, how they had that thing where they just drilled through the earth. We do it with this. This is used only in the most experienced hands because you can imagine, right? You could drive through anything with this. So you got to be absolutely sure that you're in the vein to do this, but it's another technique. So here are some of the things that we can do. What you need to know is know to the best of your ability what is going on in your body. You know, you may know, you know, my right internal jugular has been out for 10 years. Don't bother to go there. I know it's out, whatever. The more you know about your body, the better. The more you can tell us about other devices. Do you have an IVC filter? Really important because we're going to be sending wires down there. So don't forget to tell us that. People forget that all the time because you don't feel it, right? You're just used to it. It's like having a filling in your tooth. Tell us that. Do you have any other stents, cardiac stents? Do you have a pacemaker? Now we're going to see that, but it really helps to know ahead of time. So don't forget to tell us that. And to the best of your ability, what's your access history? You know, people come in and I say, well, how many lines have you had? Where have they been? And why do you not have them anymore? You know, are they gone because you have recurrent infection? Do you have a clotting history? Anticoagulants don't really help prevent clots related to catheters. We used to think that they did, and in the old days, we would give people low-dose blood thinners. It doesn't work. So that's unfortunate. Our research now is centered on catheters that repel clot and sort of like really like sort of shark skin kind of technology where, you know, the stuff can't stick to them, but there's still a long way to go. So tell us, you know, I've had 3 ports. None of them lasted more than 3 months because I got infected, you know, and we'll talk about that. And then tell us what you want and go to a practice that will listen to what you want. Okay. I do have people in my own group who will say, oh, you know, you shouldn't put a port in for TPN. And I'm like, it's not our body. Okay. My job is to sit there, chat with you, say, here are the pros and cons of the different devices that will do the job for you. And you tell me what works for you. You might say, well, you know what? I go to the gym every day. I like to swim. So I want to cycle my TPN overnight. I want to de-access. I want to go to the gym and swim. And then I'm going to go to work. And then I'll come home and at 8 o'clock, I'll access again. Now, to me, I don't know that I would do it that way, but it doesn't matter if I would do it that way because it's not my issue. Okay. It's yours. And so you tell us what you want. And if you're going to do something like a port, say, all right, where do you want it on your chest so that you can see it? Right. I might normally put it up here, but you say, well, then I have to look in the mirror to try and stick my Uber needle in it. All right. So I want it here. Doesn't matter. I'll put it wherever you want it. I'll work around tattoos, you know, anything like that. You don't want me to disturb your ink. I'm not going to disturb your ink. So, you know, that happens all the time. I had one guy, they were like this, son here, daughter here. And I'm like, oh, yeah, like, I can't do that, you know? And so he and I had a discussion and I'm like, okay, it'll go in the hair, not the face, right? And, you know, so you work that out. But anyway, wherever you want it, it doesn't matter. You probably all know a woman who comes to these meetings a lot. She's off TPN. We're in a collateral in her neck and her catheter is here because that's where she wants it. It's her life, you know? So I think the take home point there is we can sort of make the exit site anywhere you want it. And the group that you go to should listen to you on that. Okay. They may say, oh, well, I don't think that's a good idea because X, Y, and Z. And it's like, well, here's the dealio here, you know, Don had his like 4 inches away from an ostomy, which made me like a little, but it worked for him. So tell us what you don't want to do. You know, if you don't want to have an external device because you don't want this thing hanging out all the time, don't want to flush it, stuff like that, let us know. The studies on flushing are terrible. We've got some new data because of COVID. We used to flush stuff all the time. And then we're like, oh, you know what? It's COVID. Let's not flush that port for 3 months. And you know what? The ports are just fine. So less is sort of more. You don't need heparin on any of the lines that you use for TPN whatsoever. The data is there on that. Okay. No heparin. Don't need it. Okay. The longest I have had a patient with a port that was not flushed, how long do you think? 11 years. Okay, 11 years.
What do you mean not flushed? Ever?
Ever. Okay, so yes. So I get the call and I'm like, really? So I say to the nurses, well, fire it up. Let's see what happens, you know? And so they did, and it worked great. And so then I had to go talk to this patient, right? And I'm like, hey, what the heck here? You know, I said, did you just forget you had it? And she's like, yup. And so did everybody else. Because she had cancer, like whatever, 15 years ago. And literally, right, you get used to your device. And she just forgot about it and it worked perfectly. So really and truly, like if you're going to go on vacation, you know, or don't worry about it. It doesn't have to be every 24 hours on the button or every 4 weeks on the button or anything like that. Okay. We can put devices anywhere. This is a lady who had a lot going on the chest. And I thought, oh, before I met her, I thought I'll put a port in her arm. That'll work, until she walked in and she was like 85 pounds. And I'm like, oh, there is no, real estate here. So I put it over her back. And this is after only like 5 days. So you can see it's still healing. And I thought, the oncology nurses were going to kill me, you know, go, what crazy thing are you doing now? They loved it because it's really easy to access. The patient loved it, right? Most patients would say to me, see, that's why that's important. You know, I'd rather have a scar there than like on my chest or right above my breast or whatever. So I've done this a lot since. And it was one of those things where, oh, that's a really good idea. How come it took me 20 years to think of it? It's also a really great strategy for kids if you're managing children, because it's like an out of sight, out of mind thing. It doesn't matter if it's a tunnel catheter or port, right? They're not messing with it because it's back there. We can put a tunnel catheter in the arm. So it looks like a pick, but you can see that it's really not. This is a guy who was a horse farmer. So it goes into the vein here, and then I ran it under the skin and it comes out here. His elbow is right here. And this lasted about 5 years. And he just wanted a device in the arm. So why not, right? Here's a port in the leg. So here's knee, here's groin, here's the port. So I bring it out laterally, right? So it's much more comfortable. You can access it here. You wouldn't want it on the inside of the thigh, right? And then we bring the port pocket remote from the groin by a good 15 centimeters or so. You'll hear people say, oh, femoral lines, groin lines, they all get infected. No, they don't. They don't. This has lasted a really long time. The data on femoral lines comes mostly from critical care. So where, you know, direct stick into the groin, people who are super sick, stuff like that. In chronic long-term lines, they're fine. Okay. Questions for me?
I think we take questions
At the end?
together.
Okay.